Good morning, everybody. My name's David Millichap. I'm from Checkup and I'll be chairing this morning's Queensland Primary Healthcare Network meeting. It's just clicked over 10 o'clock, so I just can't see if how many people are online at the moment, but I'm sure we'll have a few people join us, but we will kick off straight away. We've got a lot to get through this morning. And I'll start off firstly by acknowledging the traditional owners of the land on which we're meeting today. For me here in Brisbane, that's the Turrbal and the Yuggera peoples. And I know we have people from right around Australia today, WA, Victoria, so we pay our respects to traditional owners wherever you're located today, and also pay our respects to elders past, present and emerging leaders. Also, just to acknowledge it's NAIDOC week next week, so if you don't know much about NAIDOC week, we'll post the web address in the chat section there in Slido, and encourage people to check out what may be available in your area, either virtually or live. As you know, we are using Slido, so we would encourage you to post questions during the morning. We will have each speaker will have time to speak and then answer any questions that do come through Slido. We also have some polls that we'll be asking during the morning. The first question's already up there. Is this your first QPHCN meeting? And we've got 62% of people attending for the first time. Our QPHCN meeting's been going for 10 years. So started way back in 2010 as a very small group of people interested in primary care, and has grown over that time to now be really quarterly workshops, usually live in our office, but this year we've obviously adapted to this webinar format, and it's proved to be even more popular, and we're getting people from all over Australia now, which is great. Today's topic is social prescribing, and we've got 5 speakers for you. I'm going to do all the introductions now, and then we'll hear from each of our speakers. Our first speaker will be Tracy Johnson. She's the CEO of Inala Primary Care, which is in the western suburbs of Brisbane. Morning, Tracy.
Morning.
Our second speaker is Genevieve Dingle. Genevieve's Associate Professor in Clinical Psychology at the University of Queensland in Brisbane. Morning, Genevieve.
Good morning, everybody.
Our third speaker is Joe Jeslinka. Joe is the Principal Consultant at LATROSE Consulting and based in Melbourne. Good morning, Joe.
Hi, good morning, everyone.
Our fourth speaker is Dr. J.R. Baker. J.R. is the CEO of Primary and Community Care Services in Sydney. Welcome, J.R.
Morning.
And our final speaker is Edie Stevens. Edie is a program coordinator for Checkup and is based in our Townsville office. Morning, Edie.
Good morning.
Okay, so I think everyone popped up on screen. So you've seen our speakers. You won't really see much of me during the morning unless there are questions. I'll ask your questions for you. All right, well, let's kick off, and Tracy will share her screen to show her presentation. So Tracy, if you'd like to do that, and over to you.
So are we screen sharing? Can everyone see my screen?
Yes.
Indeed we can. Awesome. This is always a good first start. So welcome everyone. As David said, I'm the CEO of Inala Primary Care. We're a large charitable bulk billing practice in Brisbane's western suburbs, serving a really highly multicultural community. It's also a social housing community, so for those of you living around Melbourne and parts of Perth and other cities, I guess, you know, we are the disadvantaged end of the universe. So the social determinants for health for us are very, very real, which is why when we look at the 16 GPs, 8 specialist physicians, allied health providers, and many nurses that work within our team, one of the things that we've been looking for years is how do we bring to our patients the care that they need? And that care is not always medical, but it is always personal. So we've been on a social prescribing journey for a while. So my role, I guess, in the group of wonderful speakers that are gathered this morning is to paint a bit of the context for general practice in particular, and our general practice specifically. The steps that we've taken, because things have evolved for us, hopefully they will continue to evolve for us. And most importantly, our willingness and openness to be part of a national agenda. And one of the things I'm really excited about is that today is one of a number of conversations that have occurred over the last sort of 2 years in particular around social prescribing. So I'm really keen to be part of that conversation. So for those of you that are interested and doing other things, I guess I'm here to speak, but I'm also here to listen. So for me, this is a really exciting morning. So in terms of where we're going with primary care services here in Inala, what I want to remind everyone is that social prescribing is not new. This is some detail that I've been able to share courtesy of the College of General Practice. They did a survey in 2019 in October of a few hundred of their GP members, and they asked them a whole bunch of questions about social prescribing. This is the answer to one of those questions, and what it shows is that for general practitioners who responded to the survey, and hopefully they're fairly representative of most GPs out there in the community, they're already engaged in social prescribing, whether they're engaged in the particular models that we're talking about or they're on the continuum. What we know absolutely is that nurses, doctors, allied health providers, anyone involved in healthcare is already doing elements of social prescribing. I think what has changed, however, is that historically, Medicare really anchored medicine as a free and available resource in communities, and in our community that's really important. 98% of our care is bulk billed. But I think in having doctors being such an important part of our healthcare system for so long, we have perpetuated the notion of the Lone Ranger, the doctor who can solve everything, the doctor who has magic bullets that will make your life better. And certainly there are moments where I think every doctor is able to achieve something significant with a patient. But the notion of the medical model being the only way that patients receive care and they receive support in community, I think is changing. So if you look at the language and how it's evolved over the last probably decade, most strongly, we went from talking about the medical model to the biopsychosocial model, which I think a whole bunch of us would accept, adopt and understand in our own practices. There's been this rising conversation around team-based care. So all of a sudden we're not necessarily just talking about the people in our practice, we're talking about the health and social care neighbourhood and people who might not have clinical qualifications being part of the team that we wrap around the patient. In more recent years, there's been a rising notion of trauma-informed care because we recognise that people, particularly people with complex trauma, have a whole bunch of issues in their life that unless we recognise and understand those issues, simply applying a Band-Aid solution or a pharmaceutical solution is not the answer. So we need to, in fact, understand where the patient has come from on their life journey. Then there's very exciting for me been, I guess, this rising conversation in more recent times around patient self-management. So in October, I think it was the 7th of October, Greg Hunt released a blueprint for patient self-management that was generated largely out of Victoria, but myself and others contributed to the development of that blueprint, where I think we've got the government saying it's not just up to clinicians and healthcare providers to keep people well and at home in their community. It's actually a partnership with patients and really embracing that language of patients, carers and their families being part of the team that allow us to deliver what the patient needs at the right place and the right time. So Consumers Health Forum, an organisation that a number of you would be aware of, in October of 2019 also ran a survey. They got 400 odd responses to their survey, and this was one of the questions. What would you like to see as a patient in terms of referrals and supports that you get in a clinical consultation? And what you can see from this answer is that patients were saying, by and large, if somebody tells me there's something out there, I'm really quite interested in that, I want to know this information, but there's some things that might be impediments for me in getting involved. It might be how much services cost, it might be when they're occurring and the time that they're occurring, it might be getting to those services, and most importantly, it might be about my life. Do I feel comfortable going into novel situations, and do I have other people that I might need to consider as I plan my day? And I think this is a common and typical story where for those of us that do engage in social prescribing in our clinical world, we're often a bit disappointed and frustrated that patients don't always take up those things that we would like them to. Quite clearly, patients are telling us it's not as easy as being told. Information is not necessarily empowerment. Another aspect of what stops patients from getting involved in taking advantage of things that are already happening in their community is their level of activation. So we know that patients, according to a model that was developed by Insignia in America, typically fall into 4 quadrants. So patients at the lowest level of activation actually find that the healthcare system doesn't work particularly well for them. This was a study done which quite clearly shows that if you're a less activated patient, you're more likely to represent to hospital, you're more likely to have adverse outcomes as a result of contact with the healthcare system, which builds rising disillusionment for you about how much can I even trust the healthcare system to look after me. And yet these are often some of our most vulnerable, fragile and complex patients. So we need to work with patients where they are. Unfortunately, because all of us have limited budgets and resources, one of the things that's happened with the digital revolution is that there's been some amazing tools created. So we're lucky, our PHN provides us with access at a practice level to GoShare, which is a wonderful online resource full of all sorts of information about services out there. There's a big movement in Queensland, and I know Checkup, who's sponsoring today's workshop, are part of that, to get the My Community directory more accessible and populated so that we know what are the services in my local community. I've been privileged to sit on the Black Dog Institute e-mental health committee, helping advise them around e-mental health tools. And we know that Beyond Blue and a whole bunch of other organisations have also developed a whole bunch of fantastic online resources. The challenge is that if we don't change our workflows in clinical practice, and most importantly, we don't understand the patient and where they're at, all of these fantastic resources that we might use to find things happening in our local community or that we might recommend to our patients still might not be taken up. So our conversations can end up going nowhere because the patients might not be activated enough or confident enough to take up the opportunity. So within our practice, certainly we've tried to utilise all of these things, and we know that we've still got a big journey ahead to utilise them well. But we sort of started going, well, we need some additional support. So in 2013, I discovered that in Glasgow in Scotland, and for those of you that have been to Scotland, you'd know that Glasgow is one of the poorest centres in Scotland, and indeed one of the poorest centres in the UK. So sometimes I like to say that the bricks in Glasgow actually speak their tragedy because the poor parts of Glasgow are truly really poor, horrible places. So in those very places, there was this program called Link Workers that was a creation of the Health and Social Care Alliance and GPs at the Deep End, an aggregation of GPs serving hard to serve communities. They managed to get funding out of NHS Scotland to place 7 link workers in 7 practices. I was really keen to have a look at that model, so when I picked up a Churchill Fellowship and travelled in 2015, this was one of the places I went. By the time I got there, those 7 people had turned into 15 people across a bigger number of practices. By the time I got back and wrote up my Churchill Fellowship, NHS Scotland had funded 200 link workers. What we now know, a number of years down the track, is that the NHS England group have funded thousands of link workers. So clearly this is a rising movement because general practice is saying it's not enough for me to tell the patient what to do or give them a brochure or give them an email linking them to a service. Sometimes I need a people dimension to actually really help the patient develop their own goals, develop their own confidence, and even go with the patient to these social prescribing opportunities. So one of the things I love to draw people's attention to is on this slide. It talks about a patient, and this is a real patient, who when they were evaluating the link worker program literally walked into a practice one day and said, can I have an appointment with that person in here who helps you turn your life around? I think that's an incredibly powerful statement, that a patient turned up to a general practice and didn't ask to see a doctor. They asked to see the person that could turn their life around. And this is the power of social prescribing and why we've been advocating for it for a number of years. In our practice ourselves, we have a frequent flyer population. Every general practice does. So in our practice, we've got 276 patients, 6% of our total patient group. They take up 24% of our doctor's time. When we did some modelling around this group, we realised that they're actually costing us $368,000 a year in opportunity cost of seeing patients who take less time to see and being able to build more revenue, as well as a whole bunch of other resources that we're already funding to go into these patients and support them to stay well in their community. So that really led us on a journey to rethink care. So we started developing internally some of our own social prescribing options. We were lucky to get a little grant out of the Mazda Foundation, which was enough to kick off a table tennis club and a card making group. What we found was that those things that we were running internally, our nursing team was involved, doctors were heavily involved in encouraging people to go. We also picked up another grant that allowed us to run a little bit of a financial planning workshop activity. Occasionally we ran Christmas parties and things like that to bring patients together. What we found is it was incredibly hard to get patients, even though we were running it in a familiar location, our practice, with familiar people, our team, with people they trusted, referring them to come to those events and activities. It was still hard to get the numbers that we had imagined would be interested. We also signed up to My Health for Life, which is a Queensland government funded program to help prevent chronic disease by outreaching to people who have risk factors for chronic disease. Again, we find that we can run that program fairly consistently, but there's an awful lot more people that would benefit from that. So we decided to dig in further. So we actually managed to work with the Queensland Community Alliance, again, using some grant funding, look at our patients over the age of 65, and you can see some of them there, and really ask them what was it that was going to help them become well connected as a group and to take up some of these other opportunities and become more activated as patients. So over the many years, we've invested considerable resources in really both providing services and understanding these patients. What that led to was our advocacy to a number of groups. So we have a strong, close working relationship with Mater Hospital Service. So they're a Brisbane-based Catholic system that also provide public and private care. So they funded for us, starting in February of this year, a multicultural nurse care coordinator. So they funded a 16-month trial. It's been funded through some philanthropic funds that Mater has access to. They're a nurse here 2 days a week, and they work with our multicultural patients, a lot of whom don't speak English or it's fragmented English, to help them navigate the health and social care system. And what we've found is that we're getting a whole bunch of great results. We're still obviously early days and early evaluation. It's only been up and running since February, but it was something that all parties decided to extend in June of this year for another 12 months. We were also lucky enough to get funding from Brisbane South Primary Health Network as part of a program that they funded across 5 GP practices. We became the 6th, where they have put in a social work trained care coordinator. It's a 14-month program that we're involved with. It too will end on the 30th of June next year. And 1 day a week we have access to their social worker. Again, we found this program incredibly valuable. We did need to tweak some of the entry and exit criteria so that people 18 and older rather than 35 and older could get into the program as it was initially scoped. And we still have challenges for those folks who are over the age of 65 who are ineligible for the program. But nonetheless, we will take any resources that anyone's prepared to throw at us. And this is the room that we use for those services. So you can see it sitting there. So it's not a clinical looking room. It's very much a comfortable room that people can engage with these different social prescribing agents whilst they're in our practice. So what results have we got? We've seen improved attendance by some of our most at-risk patients, both here at our practice and also at hospital appointments, pathology appointments, radiology, allied health. We have seen a small reduction in the number of GP visits these patients are taking up. We'd like to see that increase because often when we see these patients, we medicalise their social problems and they end up being tested and drugged and whatever in ways that might not be the best for them. We've seen increased access to and take up of the NDIS and disability support pensions for patients who've really struggled to get down those pathways. We've seen increasing health literacy because both of those roles have provided time with patients to really educate them about their diagnoses, about COVID, about a whole bunch of other things. And we have seen team satisfaction rise. Stress levels are going down. They're still higher than I'd like them to be, but the pleasure that our doctors get in being able to go, you know what, there's somebody else that can talk to you about this, and who knows all of these programs and who can, you know, work with you to get through things. So our team are finding this a real privilege to have within our practice. So they're the good things. The bad things, 2/3 of the work that these folks are involved with involve other agencies outside of our general practice. And yet as a general practice, we're the ones footing the cost more often than not. We provide a room, a very nice room. We get no rent for that. We get no income from that floor space, and yet it's expensive floor space. And we have to invest an awful lot of my time and other team members' time to make these models initiate as well as become sustainable. So we're funding our own evaluation of these projects so that we've got data to continue to advocate. So this is not just a free handout. This is actually a lot of work, and it would be nice to see that work acknowledged. We've also seen GPs have to change their workflow. And for anybody that's worked as a GP, you know, your windows are pretty tiny in terms of time. So supporting our GPs to change their workflow so that we can embed these teams of care is also something that we're continuing to have to invest in. So that's our story. It will continue, hopefully. Maybe it will inspire you, but we'd love to see such things happen more broadly. So some other models are going to be talked about by my colleagues. So thank you for this opportunity. David.
Thanks very much, Tracy. We do have a question. It's from Helen Hayden. Helen asks, if there are barriers of travel and cost to accessing the non-medical services, and I guess maybe COVID now, have telehealth services been used in this space?
Yes, so we continue to deliver some of our services using telehealth, but sometimes the things that we want patients to engage with, like going to a hospital, for example, when they need to visit an outpatient appointment and things like that, we can't necessarily always dictate the venue that these things will occur in. So consequently, the patients sometimes do need to travel, or if they want to get involved in a gardening club or a chess group or a church activity or whatever. We live in a community where 20% of households don't have cars. So transport for us is perhaps a bigger issue than it might be in other locations. And it's something that these care navigation and social prescribing people actively work with to get people free travel vouchers, to get them using the community flyer bus service, to help them navigate bus systems, all sorts of stuff so that patients can actually get to where they need to go. You're on mute, David.
Yes, I was. Sorry. We've had a couple of people also ask for PDF copies of the presentations, and we'll get those to people. And a final question to Tracy. Do these programs link with the NDIS and the disability sector? How has that gone? And that's from Claire Bartholomew.
Certainly, some of the work that our folks are doing does involve NDIS access and service providers. So Amparo, which is a fantastic multicultural NDIS provider here in Queensland, getting patients who are multicultural to accept their disability and do something with that and navigate the NDIS system can be quite hard. So our multicultural nurse coordinator and Amparo are building more and more relationships. Likewise, other NDIS providers, helping patients actually access the NDIS system so that they get a fair assessment. If you're not very good at advocating for yourself, we find that the NDIS system doesn't always give you the services that perhaps are available if somebody else advocated on your behalf. So some of the work of these people is in fact helping folks access the NDIS system.
Thanks. I did say last question, but actually two more on a similar theme have popped up. It's around GP workflows. One's from Suzanne Martin. You mentioned changing GP workflows. How challenging has it been to get buy-in from GPs given the short-term trials? And Peter Larter from Larter Consulting also asked about how you changed your GP workflow. So yeah, Tracy?
We're really lucky. So we have people who come and work here because they're incredibly committed clinicians. You don't come and work in Inala if you want an easy ride. To get a better ride, given the complexity of our patients, we work really hard as a team. So we always have grand round meetings happening once a month with our teams. We have lots of lunchtime workshops and stuff where we co-design and redesign things. A lot of practices find that challenging. They find their GPs want to work behind a closed door and tell the practice what they want from the practice. We're lucky we've deliberately recruited GPs who want to work and learn from each other and who want to work common systems, and they're prepared to be involved in designing those systems. So that's how we've done it, is by using lunchtime workshops, nighttime workshops, some of which we fund their time, quite often we don't. And we work together to figure out what we're going to need. And they do that because these patients end up with bad outcomes, and that makes the GPs feel horrified and guilty. So if they've got a resource and they've got to figure out how to use that resource well, they're happy to spend the time talking with each other about, well, what did you do and how did you get that result, and how could we design that as a system so that we can all get that advantage together. And likewise, they're involved in the evaluation of the work. So we've got a number of interim evaluation milestones where our GPs are actively involved in helping us shape and perfect what we're doing. But they're a very engaged, very committed group of 16 GPs, so we're very fortunate.
Thanks, Tracy. There's another comment from someone who works in NDIS, and I'm just going to cut and paste that into the Q&A panel. So there's some information for people on the line today. Thanks again, Tracy. We'll wrap up there. We'll move on now to our second speaker. We have Genevieve Dingle from UQ. So Genevieve, over to you.
Thanks very much, David. Hopefully people can see my slides. Yeah. Okay, so I'm from the School of Psychology at the University of Queensland, and this will be a sort of a researcher's perspective on social prescribing. So I've just called it social prescribing. What is it and why should we care? So I'll pick up on a point that Tracy already made, is that in every primary care service, there'll be a small number of patients who are coming frequently, who are frequent attenders and are taking up a sort of disproportionate amount of time and resources in the service. So a couple of years ago, Tegan Cruis, myself and some colleagues in Scotland had a bit of a look about, could this be something to do with social isolation and loneliness amongst these frequent attenders? And we were sort of looking at this idea that perhaps those folk are coming and really looking for something, but it's not really a medical solution first and foremost. It's maybe a social solution that they're interested in. So we had a look at this hypothesis in 3 different studies. This is a bit of a busy slide, but I'll just give you the sort of headlines. So the first group were 1,700 odd patients to 5 Scottish GP centres. The second group were 79 international students who just arrived in Australia to study at a university. And the third group were 46 people who were already disadvantaged, sort of people with chronic health and mental health kind of conditions, who had joined a group as part of the RepLink network that some of the listeners here will probably be familiar with. So across all of these different types of samples, we were looking at how does the number of social groups and social programs that person is involved in relate to their use of GP appointments. And so we found across all 3 studies that even accounting for demographics, age, gender, socioeconomic status, looking at outcomes on physical health, it was really a very strong relationship between the number of group connections the person had and their use of GP service time. And in fact, in this final study here, it was more of a intervention study where we looked at GP appointments before starting a group program and then after starting in the last 3 months. And it significantly decreased because the people were getting those social needs met within a new sporting or recreational or arts-based kind of group program. I want to just take a little bit of a segue here to talk about my background and sort of coming into the social prescribing space. I've been doing a number of arts-based group programs. So the folk on the picture you see here are the Absolutely Everybody Choir, which operates in Brisbane as part of Upbeat Arts, which was formerly known as School of Hard Knocks in Queensland. So some of you will have heard of School of Hard Knocks, either in the Melbourne group or in Queensland. So we had a look at a number of their arts-based groups in the community, so the choir and the creative writing group, and found that in joining such a thing like a choir or a creative writing course gave those people who'd had, they have chronic health and mental health kinds of conditions, it sort of helped them to move away from this life that was very much centred around their identity as a person with, say, schizophrenia, or a person with, you know, a long-term chronic health problem, to, say, a tenor in a choir, or a person who really likes to write poems. So it was a real shift in how they saw themselves. They built this kind of meaningful group in the community that they were doing something with every week. And that shift sort of led to some really positive social and mental health kind of benefits. So we've published a number of studies from those sorts of projects in sort of in the context of chronic mental health, but also in aged care. So people in retirement villages also feeling much more connected and cognitively healthy. So a number of those sorts of pieces of evidence have fed into this idea about social prescribing. So there are three components of social prescribing, and I think it's very important to have all three. So first of all, there's the referral, which might be from your GP or from a practice nurse or someone else in primary care, to the link worker. So there's a number of discussions with the link worker where they sit down with that patient, get to know them, what they're interested in, where they live, what their different barriers and difficulties and challenges are, from practical things like, you know, financial, transport, mobility kinds of issues, all the way through to what is available for them to access in their local areas. And they generate a list of potential things that they could try. This is an ongoing thing. My understanding, talking to the link workers that I'm working with in our project, it's never an easy sort of one, two, three step. It's often a number of different meetings and solving problems and helping people to engage with a personally meaningful group to them. And there's a whole range of things that might involve. So here's just some of them on the screen. So as we talked about before, it might be a community choir, it might be a skills class, an adult education type class, it might be a book club, it might be the men's shed doing sort of, making and trades type things, it might be exercise and gyms, it might be outdoors. So there's a whole range of things that people may feel that they'd like to try or have done previously and are just unsure about where to start. And let's face it, none of us want to go and join a group of people we've never met before by ourselves. That's a very human thing to feel that that's quite a daunting prospect. So I just want to focus a little bit more on the role of the link worker and why I think it's really an important key to the success of these social prescribing networks. And trying to think through what is a link worker. So we know it's not a therapist. So my background in clinical psychology, it's a very different thing to what I might be doing with that patient in the room. It's not case management. So it's not doing things for the person, like helping them, just get their pharmacy prescription filled or, those sort of very practical things. It's different from those two. So the link workers have to hold this mapping knowledge of all of the different social services and programs in the area and keep that updated. And so, of course, that needs to be an ongoing work to find out what's going on and is it still going and who's running that, and do I know the facilitator? Can I vouch for that person and pick up the phone and make that referral to someone that I already know? They then have to assist the client to access those social group programs, and that sometimes includes attending with them for the first session or two until they actually feel more comfortable there. And as I said, they help the client to overcome very real barriers to attendance. So that can be anything from psychological barriers like mistrust from having had negative experiences before. It might be fear of others judging them, a sort of social anxieties, lack of confidence, a whole range of things. It also very much includes advocacy. So picking up on the point and some of the questions before, the link workers are often helping people to navigate NDIS, domestic violence, housing support, mental health services. So they're also helping to dovetail into existing outside services that can help them meet their full needs. And very importantly, they don't just send them off to a group and leave it at that. They very much actively follow up and make sure that the client feels a sense of connection and belonging and engagement in that group program. If it's not a good fit, they will keep trying. So there'll be another option to try. So what does the evidence tell us about social prescribing? Well, it's important to note that there are no RCTs yet for social prescribing in terms of outcomes on loneliness or social isolation. So it's important to put that up there straight away. What there is though is a number of reviews and empirical studies, and they're really, growing in the last sort of 5 years or so, particularly coming out of the UK. So this one by Helen Chatterjee and colleagues was a systematic review of 86 schemes that have published results in the period 2000 to 2015. So that included some quantitative, qualitative and mixed methods. And these were the sorts of outcomes that they found. So things like increased self-esteem and confidence, sense of control, empowerment, improvements to different measures of mood and mental health, reductions in anxiety, depression, and then a range of things about how that affects general practice, things to do with social and communication skills, acquiring new skills, learning new things, reduction in social isolation and loneliness, particularly for those hard to reach people. So kind of a range of different positive outcomes have been reported in different types of methodologies, but we don't have a study where people have come in and then been randomly assigned, let's say, to social prescribing versus treatment as usual. We're not at that point yet with this body of research. This one has recently come out from our colleagues in Nottingham in the UK. So they looked at 630 patients and followed them up 4 months after they'd been referred into a social prescribing network. And they found, so this one actually includes interviews with prescribers as well as link workers as well as 630 patients. And they found that the patients valued the different social relationships they created through this social prescribing pathway, including with the link workers and the groups in the community. The group memberships quantitatively predicted primary care usage, and this was mediated by increases in community belonging and reductions in loneliness. So that prediction was actually a negative one, where they were relying on primary care sessions less if they were getting a higher sense of community connectedness and belonging. So that's the kind of theory behind what we're trying to achieve here. But as I say, we've still got a long way to go in terms of the data. So here's a couple of quotes from Bertotti and colleagues, which was an interview-based study. So with GPs and service users, this GP is saying, the terrible thing is I referred 5, meaning 5 patients, but I should have referred about 15 times that. Although I'm very enthusiastic about social prescribing, it's hard to keep it in front of your mind, and that's the challenge. Over here in the pink, she was just absolutely wonderful. She was just right. I told her what had happened, and that seemed to get it out of my head a bit. All these years, it's just been in my head. So that's from a client or a service user. Down here in the orange, I have no idea who or what you're talking about, but sounds like a good idea. I don't know why I was referred. So here you can see the issue of really clear communication all the way through the social prescribing about what the point is. You can imagine how it could go very pear-shaped if you've got a patient who's a frequent attender who you think they've got some unmet social needs, and you've heard them talk a few times about how they'd love to go gardening or they'd love to go to the botanical gardens, and you know that there's a gardening club down the road. And so you suggest that they go to the gardening club, but they might have no idea why they're there. And that could actually make them feel like they haven't been heard or they haven't got the answer to what they're thinking they need medically. So it does need really clear messaging, both from prescribers, but also from service users. And this last one here, best thing has been meeting new people and making friends. My mobile is full up with names and numbers of friends. Before it was just family and my doctor's number. So again, you're growing the networks of support for people who may otherwise be not working, not studying, not sort of participating in the usual kinds of communities around them. So just very quickly, this is the one that my team at UQ are currently involved with evaluating. So it's called the Ways to Wellness Social Prescribing Project, and it's in the Mount Gravatt and surrounding suburbs here in Brisbane. The website is there, so please do hop on and have a look what's happening at Ways to Wellness. This is sort of an operational model. So we're varying it. This is a community-led model, so we are varying it a bit from those UK ones that are very much GP-led. So these referrals can come from the lonely person themselves or from a range of different referral agents, so other health professionals, NGO workers, etc. They meet with the link worker. There's 2 link workers now based at Mount Gravatt Community Centre. They get to know them and find out a little bit about their interests and, you know, their location and barriers and all that sort of thing. If they already have a clear idea of what they'd like to try, they can go straight to a whole range of different community programs. If they don't know where to start and what to try, they can come to our Groups for Health intervention, which is a UQ-led 5-session group intervention, which runs within the community centre itself. We've just started the 2nd cohort of Groups for Health last week. And that one is where people learn to map their own social world, work out what they're interested in and sort of self-manage their group memberships. So it's a skills building program, if you like. So the aims of this research, which has been funded for 3 years from the Australian Research Council, is to find out how effective social prescribing is for 150 clients. So we're looking specifically at outcomes on loneliness, wellbeing and community engagement, but we have a range of other sort of measures as well. We will have a comparison sample recruited from GP clinics who are not being referred into the social prescribing. We will be looking specifically to build and test a theoretical model, so looking at the mechanisms, if you like, for how does this work best and who responds best and what are the key ingredients to that. We've actually, because of the COVID impact and all the social groups closing down, we've had a bit of time on our hands this year to make contact with a number of other social prescribing networks around Australia, and actually Tracy at Inala Primary Care and JR, who you'll hear from shortly at PCCS, 2 of those that we'll be benchmarking with, which is really exciting. And we've also been running an interview study with link workers around these different sites across Australia to find out exactly what they're doing, what their role is, how they're funded, what the difficulties and challenges are, and how they're helping clients to overcome those. Because we need to know more about what's happening in the Australian context that makes us quite different to what's happening in the UK and elsewhere. So for me, and this is my last slide, the ultimate aims of social prescribing are that more people will get their social needs met in the community. They will have an increased self-management of health and well-being. There will be an increased utilisation of existing community-based programs, because there are fantastic community-based programs, but I feel like at this point, a lot of them are underutilised, and that's a shame because those are resources that are already there. They may relieve a burden on the primary care system or leave those appointments for people who are in more acute care sort of needs. There may be a possible decrease in prescriptions. So we do in Australia also have a problem with long-term antidepressant prescribing, overuse of pain medications and those sorts of things. And for me, it'll be a real revolution to see healthcare as much more than just that sort of what happens in the hospital and the GP surgery, but think of it as what happens in that person's life that keeps them well in the community most of the time. So just wanted to say that all of this comes with a team. So this is my team here at the University of Queensland, and also acknowledge the funding that we've got for the from the ARC. So thank you so much.
Excuse me, thanks Genevieve. At the moment we don't have any questions there. Just reminding people that there are polls as well. So about half the people have answered our poll questions. So just look on the right hand side and you'll see a polls tab. If you could answer those, that'd be great. And remember, you can keep questions coming throughout the morning. We're a little bit behind schedule, but we'll soldier on. Next we have Joe from LATROSE Consulting. So Joe, if you'd like to share your screen now, we'll hear from you. Thank you.
Hi everyone, good morning. I'm going to jump straight into it, sensitive of our time restrictions this morning. So I'd like to begin by acknowledging the traditional custodians of the land where I am in Victoria today, the Wurundjeri people, and pay my respects to their elders past and present, and extend that same respect to Aboriginal and Torres Strait Islander peoples here today. After Tracy and Genevieve's presentations, I would like to take a few steps back to provide a different lens and share with you some of the work we've been doing in co-design, in a way that builds on some of the barriers to participation in particular that Tracy spoke about up front. We've had the opportunity over the last 2 years to work with some communities from the ground up to develop their own social prescribing models. Today, I wanted to share just a very rapid overview of some of the approaches we've taken to develop these models from scratch in a way that responds to community needs and priorities. I'll briefly speak to 2 different communities, 2 different objectives, and 2 different methods. Here in Victoria, we have a rapidly increasing appetite for social prescribing. We know the evidence that there are positive outcomes, and obviously Genevieve's just touched on some of those. We have different communities coming to social prescribing to solve a myriad of local challenges. And we have funders willing to work with us to look at innovation. What we don't know is the precise model for each community that will make it fit for purpose. For example, what is the community and local health sector's appetite for social prescribing? Its acceptability. How can we design a model that delivers on person-centred care and that delivers meaningful and genuine outcomes? How can we make it feasible, appropriate, effective for that particular community? At its most basic, here we have a demonstration of the skeleton architecture of a model. On the left, we have individuals who may be prioritised or targeted to receive social prescriptions. In the middle, we have the different referral pathways into the service. And on the right, we have what I call the prescription pad, the community assets that have been mapped as available for that community, and hopefully they've been verified as welcoming and appropriate. Some of what we don't know in building a model, some of the unknowns, include the prerequisites for establishment, local partnerships availability, the policy environment required, appropriate settings, pathways in and out, opportunities for innovation, and sustainability considerations. So the first of 2 cases I want to speak to today is Latrobe Valley in Victoria. Latrobe Valley is a regional area with a population of 74,000 across 4 townships. The area includes populations with multiple intersecting disadvantage and complexity and intergenerational issues, and with health outcomes very much the product of social determinants. The state government is looking for innovative ways to improve health and wellbeing outcomes for this community. And the overarching questions for us in co-designing a model are, is social prescribing for us? And if so, what should it look like? And how can we build on what we already have in the community? The co-design approach we took to this work was 3-pronged. At community level, we sought to hear from likely social prescribing participants and those who might be harder to engage. At general practice and primary care level, we worked with general practices in the region to understand the conditions required to successfully engage general practice into social prescribing. We also worked with the community sector to understand the context of organisations and groups that could comprise the local prescription pad. For the purpose of today, we're only going to be discussing the community co-design process. You can see on the screen there some of the questions we asked of community members about awareness of local community groups and services, about any previous experience of social prescribing they had had with their GP, about preferred language and terminology, and about their personal needs and interests, including their support and non-clinical needs. We developed a mock prescription pad to jog people's understanding of what this could look like. We iterated and updated this when people made new suggestions. Our work had a very specific focus on groups of people who are likely to benefit from social prescribing, including some of those that we've already mentioned, people living alone, living with complex mental health or multiple comorbidities, those experiencing financial distress, lonely older people with a focus on men, and socially isolated people. We also had a very specific focus on engaging community members who may be out of touch with services and support, and used a number of community settings to reach people, such as libraries, food and crisis relief, law courts, shopping centre food courts, bus stops, laundromats, work for the dole programs, and opportunity shops, amongst others. I'm including here just a snapshot of some of our findings to share with you. But when we asked the question about personal needs, what's most important to you, you can see over and above all the other responses that people are looking for somebody to talk to have a conversation with. People are also looking for something meaningful to do with their time and to feel more connected to people and to be part of the community. When we asked what matters to you, what are you interested in, as a way of us generating an idea for what the local prescription pad should look like, obviously we were happy to see health and wellbeing at the top of the pops, but we heard repeatedly from people around working on my strengths, goal setting, improving self-esteem, improving confidence, some of the key life issues that people needed some support with. The majority of community participants supported the introduction of a social prescribing model. However, we heard loud and clear the minimum requirements for participation. Many people told us that they needed someone to accompany them to a prescribed activity, at least for the first time. They needed transport to the activity, and they needed low and no cost activities, which we've already heard a little bit about from Genevieve and Tracy. What we also heard from community members about was the importance of the GP relationship. While some people have a regular GP who can be a source of influence for them, a significant number of people we spoke to did not, and would possibly be uncomfortable in having a conversation about some of their non-clinical needs with someone they didn't know. A large number of people were not overly familiar with what was available in their local community in terms of services and groups, and again that builds on what Genevieve was saying in terms of underutilisation. And a large number of community members told us repeatedly that a prescription alone from a GP was not enough, that in fact the additional support from a dedicated worker was required to actually engage them. We heard repeatedly about the risks of not being able to follow through with a prescription provided. People highlighted to us they needed a worker to motivate them, to accompany them, and to follow up and help them reflect on the experience. Some of the key attributes of a dedicated worker should include having the time to get to know me, i.e. longer than the 10 minutes I'm likely to get with my GP, to understand my strengths and my hesitations, needing someone that had exceptional engagement skills, who had an empathetic, respectful, empowering and non-judgmental approach based on principles of active listening and trauma-informed care. In exploring the terminology of social prescribing, there was mixed acceptability of the terms. For some people, the concept of prescribing was too formal and too disempowering and too medical, whereas others place a high value in a prescription from a trusted doctor. For other people, again, the sense of community connection was an important component to be a feature of the name and the language. We received some local suggestions from community members around the terminology, and we've incorporated them into the model. So in terms of the recommended model that we landed on for this community, I won't go into too much detail on this slide, it will be shared after today, but I guess highlighting the key points. The approach is to be town-based rather than across the whole local government area. The service is to be delivered by a dedicated worker co-located within general practice and a community setting, such as a community centre. The engagement of participants was to be underpinned by something we're calling a social health check, which is a screening tool for social determinants to engage general practice patients into a conversation about social prescribing. And you'll see on the right-hand side, for trial purposes, a number of prioritised cohorts have been identified, including a combination of frequent attendees at general practice and 3 or 4 of the population groups that were identified as priorities by the community. So to jump straight into our second case study to provide a contrast to Latrobe Valley, the Macedon Ranges work we've done emerged from a community's desire to provide better support for people in suicidal distress, and more broadly for people living with mental health issues in a rural and regional context where mental health stigma is still really significant. It's a community trying keenly to find ways for earlier intervention to prevent crisis. A key focus for model development here was, how can we use what we already have in the community? How can we use our assets, and especially our human assets, people willing to volunteer their time? Our co-design approach for developing this community support model was informed by people with lived experience of suicidal ideation at every step. We formed a group of lived experience project advisors, about 25 individuals, who guided us at key decision-making steps. And we had conversations, consultations, we ran a support needs survey and ran co-design workshops. We tried to identify what the local priority support needs were through survey and conversations, looking at the 4 different groups of needs: practical, social, emotional, and peer. And you can see on the right-hand side there, the priority needs identified from highest to lowest. In terms of what else we heard from people with lived experience about what was valued in a developing model, people want a service to inspire confidence and hope towards recovery. They want peer support to motivate them to self-manage their own health needs and to provide connection to others in the community. They want a genuine alternative to traditional clinical mental health and hospital services, an alternative which is person-centred and empowering. And they want to focus on support rather than what is wrong with me or my diagnosis. And finally, they want simplified access and pathways, part of which is no requirements for a particular diagnosis or a certain level of acuity to be able to access the support. So again, what we landed on for this community is a peer-led social prescribing model for mental health. There is a lot on this page, and I'll just draw your attention to the key components that I wanted to speak to this morning, which is the idea of using a pigeon pair of workers to deliver social prescribing outcomes in the form of a community connector or a link worker and a peer partner or peer support worker. So this partnership between the paired roles is designed to lead to increased engagement and social connection for people living with mental illness. The peer partner delivers on emotional and peer support needs and is key to engagement, especially of hard to reach or disengaged community members. This role provides empowerment and builds trust and safety using their critical lived experience peer skills. The community connector is the link worker who is supported by a bank of volunteers to deliver on social and practical support. I'll leave it here for today. This has obviously been a very rapid fire walkthrough and our 2 examples of community co-design to develop local and feasible models of social prescribing. I'm happy to take questions now if we have time, or I have provided my details for any follow-up queries for anyone who might be interested in developing their own co-design approach in Queensland and beyond. Thank you. Thanks, David.
Thanks so much, Jo. There are some questions there and quite a few around the link worker, but we might have a time, if we've got some time at the end, we'll go through those questions if that's okay, but we'll press on with our next speaker, which is Dr. J.R. Baker. So J.R., do you want to share your screen now?
Sure. That work?
It's about to. Well, it's just, oh, there we go. Yep, perfect.
Okay. So I thought I'd just run through a practical application of social prescribing model we've used quickly, and I'm conscious of the time, so I won't over-labour it, and just want to acknowledge Southern Cross University's contributions in terms of the evaluation. So just by way of background, PCCS, we kind of specialise in supporting people with complex needs. It doesn't matter if it's long-term health issues or mental health issues or injury. We tend to like, the more complex the better, I suppose. We originally started as a Medicare local, so we came to social prescribing in that sort of space, and we're looking at doing a lot of stakeholder consultations and found that people often had non-medical issues that were affecting their health and well-being, which is unsurprising. And looked overseas at different opportunities that we could try to pilot in Northern Sydney at the time. And so we landed on Plus Social, which was our model of social prescribing, and it was aimed at people with severe and persistent mental illness and complex needs at the time. So for today, I want to talk through a modification of that, which we applied to injured workers. So it was a bit novel to apply a social prescribing model to injured workers. Work cover systems tend to be complex and very medical legal heavy. And a lot of the nominated treating doctors or GPs involved in the care of those people had a lot more complexity engaging with the system, I think you could say. So we adapted our social prescribing framework to take into account New South Wales work cover, general Medicare services, NDIS, all the sort of Australian services, and the iCare Foundation, which is New South Wales government entity, generously funded a pilot for us. So Plus Social for injured workers, on the right side of the screen, you'll see it's a pretty straightforward model. GP or nominating treating doctor gives a referral. You get to meet your link worker, talk about your needs and goals, get connected with local services outside of the scheme predominantly, although we could also work with people to connect people to the right services in the scheme, do social participation activities, get social, and then have that sort of ongoing relationship and follow up with the link worker. Because of the complexity of a lot of the issues people had, we picked quite well-skilled link workers, so predominantly social workers and OTs in the first instance, but they had to not necessarily leverage that skill set in providing the services, which was an interesting challenge. Eligibility, I'll just run through quickly. People pretty much had to have an injury greater than 6 months and psychosocial barriers attached to it. And there was a variety of activities that people could access, from arts and crafts through to equine therapy, walking groups, and everything between. We also help people access mainstream services outside the scheme, such as the NDIS. For people exiting the work cover in New South Wales, if you don't have severe enough injury, you have to exit within 5 years. So we were doing this program in that transition period where people were exiting who thought they'd have a lot longer on the scheme when they got on it. So that was an interesting challenge too, but not enough time to talk about it. The theory we had was obviously that stronger social relationships and connections and social capital were helpful in recovery, that the job satisfaction obviously would help with recovery as well, and that in a sense people actually could lose their, it's not written there, but the social muscles in a sense. So if you're not exercising your social muscles, that you kind of actually lose some of that capability. So COVID's a kind of interesting example. People get freed from, depending on the city you're in, but obviously I'm originally from, well, a lot of places, but my family's all in Melbourne. So now that they're able to leave the house, they actually feel quite uncomfortable going to cafes and things, and it feels quite odd and jarring to engage with people. So people off work for 2 or 3 years often actually have that same sort of experience of having avoided places where they might see previous colleagues, and that sort of avoidance led to this almost learned agoraphobia sort of response, which was interesting. But be that as it may, other people have already talked about a lot of the opportunities social prescribing potentially offered. So less health service utilization, less medication, better inclusion, and really the key sort of components were obviously having a person-centered approach with good trust with the link workers and competency there, and resources to actually link people to. So the main questions we had were, would people actually feel greater social and economic confidence and be more able to participate as a result? Better psychological well-being and decreased health service utilization. Just might skip through. It was a pretty normal sample, pretty well split between males and females, mostly born in Australia, but in line with national averages, predominantly English spoken at home. So suffice it to say, the sample was pretty representative for the state, and the mix of workers' injuries were pretty much a third for less than a year, 1 to 2 years, and greater than 2 years. So after the social prescribing intervention, there were significant increases in people's actual ability to work in terms of certificate of capacity, capability rated by the GPs, their actual confidence to return to work, where we used a visual analog scale to measure that, and the actual capacity reflected on their certificates. In terms of social participation, I think it's kind of meaningful that the number of people that they could count on increased. I know in parts of the US, people feel like there's less than one person they can actually rely on for support. So to get towards an average of 4+ people was quite good. And the satisfaction with those social supports also increased. and the number of people without social activities decreased over time, so as you'd expect. And I think I would love to say a lot more, but I'm conscious of the time. Biopsychosocial well-being, everything that you'd want to go up went up. So quality of life overall, physical, social, environmental, health status, and UK10 for psych distress went down. The number of needs not met went down. So all the things you would want to go down, like pain and loneliness, they all went down. And I think the quote on the left, I'm becoming more positive, optimistic, and calmer, stronger and capable of managing my pain and mental health issues. I do not see myself as an injured worker who is lost, stuck, depressed, heavily medicated, and lost. I see myself with an injury that limits my mobility and not myself. That sort of story came through consistently across all the people in the service. Health service utilization decreased like you'd also hope. So hospitalizations decreased over the period of the study, and also the weekly contacts with their GPs went down nearly by half. So the quote on the right, since being on the program, I have not been to hospital, I have not had any anxiety attacks. And people were generally quite satisfied with the program. So about 70% of people found it better, far better than they expected. And they didn't even realize what they could actually access at the time. So simple stuff, sometimes accessing super early, financial sort of restructuring, those sorts of things, people never actually had the access to link to, but they could get a rehab service, which would possibly make them more suitable to return to work from a proficiency perspective, but not actually to life with managing their relationships in their house and their finances. So in summary, that program was quite good at promoting social and economic participation, overall well-being, and decreasing health service utilization. And the things that people valued the most were the link workers, so the quality and effective support they provided, the activities that would help decrease loneliness, increase sort of positive interactions, and then obviously the skills and sort of health literacy that developed over that time period. Skip the next slide. Just in terms of other programs in the Gold Coast right now, we're running a social prescribing program for people with term and serious mental illness. So any GP or psychiatrist in the Gold Coast can refer into that. And that's generously funded by Gold Coast PHN. And there's a combination of things available there, from obviously link work and the social or economic participation activities. There's also co-located services there, like the NDIS and Centrelink, domestic violence services, and social activity services. And then there's also complex care coordination, service navigation, and all the sort of allied health services available as well through a patient-centered medical neighborhood type model. There's an example of the service in the Gold Coast. It also has after-hours drop-ins, and here's some of the activities with happy people participating. So art's always popular and tends to oversubscribe, so we keep putting more on and it always fills out and we never have enough. And obviously things like yoga. There's also things more aligned with physical activity prescriptions. So there's some EP-led groups and some walking groups and mindfulness groups, and there's other things, practical things like cooking and photography and equine therapy and a range of other things. So just as a taster, and that's the after-hours drop-in. And I think that'll be enough for me because I'm sure I'm over time. There's also opportunities in Northern Sydney if anybody's, or Metro New South Wales if anybody's looking at that. But feel free to email me if you have any other questions, and I'll stop there.
Great. Thank you, JR. And yeah, this is really, I guess, just the start of conversations. I know there's lots of interest, and it's great that people are providing their contact details. So I'm sure there'll be follow-up following today's meeting, people making new connections, which is really what the QPHCN meeting has always been about, making those new connections. We will move on to our final speaker, and then we will, for those people who can stick around, we might extend it to 11:30 if people are available, but we'll do the final presentation. If you do have to leave, that's fine. So our final speaker is Edie from our Townsville office. So Edie, I'll hand over to you. If you can share your screen now.
Yes, I just try to get it on.
There we go. That's perfect.
Got it?
Yep.
So I just wanted to start off and respectfully acknowledge the traditional owners and custodians of the land or sea which we meet today. I am based in Townsville, so that's the Walkarookabar and Bindal people. I also acknowledge that we have a number of parties joining us today from other regions of Queensland and Australia, and I would also like to acknowledge the traditional owners and custodians of these regions and pay my respect to elders past, present and future leaders. So I just wanted to talk today on a pilot project that we've just started at Checkup. It actually started in the Darling Downs and West Moreton region, and we really wanted to look at how something might look in a rural and remote context, really low resource and low cost way to really start talking about social prescribing in this context. So just a bit of background. In terms of Queensland, it's a bit different to some of the other states. 50% of the Queensland population actually live outside of Brisbane. So I know in Victoria, everyone's in Melbourne, but yeah, there's a lot of dispersion. And of course, this brings different challenges in how people access and interact with their healthcare. We're all aware that people in rural, regional, or remote areas, their health is poorer than their counterparts in metro areas. And the way that people in rural and remote areas access primary healthcare often differs to those in metro areas in terms of resources and how it looks. The facilities are generally smaller, there's less infrastructure, less funding, and often these like GP clinics have to provide a broad range of services to their population, so they're often doing a bit more work than just your average GP. So like I said, started West Moreton Darling Downs, and it was a bit of a pilot. We brought it up north and just wanted to have a look at how something like this might run. So what we did first is wanted to have a look at kind of barriers that the GPs had to making referrals to lifestyle modification programs. So we looked at, we did a big survey through the whole North Queensland PHN region, and in that region there's Townsville, Cairns, Mackay, and then there's a lot of small towns that are low resourced as well. So we did this survey and literature review to have a look at some of the barriers that they faced mostly when they are making referrals and going forward. So unfortunately, when we were doing this survey, it was just the start of COVID-19, so we didn't get as many people on board as we wanted to, but as you can see, we got a few categories of the barriers across there, and that came up in the literature as well, so that kind of all tied together. Oops. And in terms of the enablers, we asked all the GPs as well what would help them in order to work with their patients to attend lifestyle modification programs. And a lot of the things that they said was they just weren't really sure of what was available. So I think that's come up in some of the presentations earlier. So really they wanted to know themselves what was available in their area and all the resources that they could get. So kind of from that, we said, okay, what we want to do is improve the knowledge of the current physical activity recommendations and population trends for the staff that we were working with across these areas. Again, there was a whole lot of different clinics that we were working with who really were wanting to be engaged in this space, and we were trying to figure out how we could do that with as many people in as short as time and as low cost way as possible. So we thought about making some tools to help with advice and referral and how to work with these GPs and other health professionals to get them from one level of the appointment into the lifestyle modification program. So this was really a pilot project to look at how to make that link. So in terms of lifestyle modification program. We just use that as the umbrella term that encompassed any number of services from EPs to nutrition programs, community mental health initiatives, exercise programs, and all of that. And while we were planning this, we did recognize that the effectiveness of this project would be completely dependent on the complex interactions and relationships between patients, health providers, contexts, resources, and services. So we know that all these things are interconnected, but once again, we just wanted to pilot this in our community and see how it might work and if it would be useful to patients in these rural and remote areas. So what we did first was, and I think it was being mentioned, we partnered with GoShare, which is an online health distribution content platform. So that enables the sharing of health resources. So what I was able to do in my job was actually do all the mapping and check in with all of the lifestyle modification programs in each area, get in contact with them. So then we were able to put that all online. So I think you'll be able to see, we put our own tile up there. So Cairns, I've got just an example, we put everything up there. So we had that list and we knew what was going on. And then the GPs actually could use that with the other health bundles that are available on GoShare. So unfortunately, we didn't have funding to get the link worker, so we decided to pilot this as our kind of interim link worker to see if we could get the GPs referring people to these programs. And I think during the trial period, we got about 30 GPs onto GoShare, and they were all people who self-identified as being willing to take this on and really were engaged in that space. And alongside that, we also created the exercise prescription to give to the GPs. Again, so all the GoShare bundle gets sent and emailed to the patients, and so the next step for us was getting that exercise prescription so they had actual written advice to go with the tile. As we've said before, it's really hard to get patients to turn up to these things without that written support, so that extra support. So we're hoping that written thing would help a bit in that, and there's been some evidence that it has been it's more useful using that than nothing. And we also did this question and answer thing. So we were working with practice nurses and GPs and other health professionals, just with some evidence and how they could help patients through those stages of motivation. So like you can see here, there's pre-contemplation, contemplation, and some examples of what they can say and how they can help patients get that motivation to join the program. And on the back of that was just some information about how to use the green prescription. So that's where we're at currently. We're fingers crossed hoping for some more funding so we can expand that project and look at other options to see how it would work, and then do some eval on that and move forwards. But at the moment it was just looking at our populations here and how to increase those referrals in any way we can. So yeah, I think that's it from me.
Great, thanks so much, Edie. And thank you to all of our speakers this morning. I'm just noticing the majority of people are still online. We've only had a very small drop off, even though we're just currently 3 minutes over. So we might, if that's okay, just go for a few more minutes. Clearly through the questions, sometimes we have webinars and there's very few questions, but today there's obviously a lot of interest in this topic, which gets us thinking about perhaps we need to do a follow-up this time next year or sometime in 2021. Checkup hosts 4 of these meetings on different topics each year, so certainly the level of interest today has been very high, so we'll certainly look at that. There were some questions around link workers and their qualifications. So who would like to address that? Tracy or Genevieve, perhaps?
Okay, I might go first. So when we're dealing with people who struggle to navigate the system, health and social care, as well as perhaps articulate their own goals and stay motivated around what their goals are, we're clearly dealing with a more complex person. So the sorts of communication skills, the sorts of activation and coaching skills, the sorts of trust building skills that these people need are going to be exceptional. Where those skills are found, well, clearly social work programs, occupational therapy programs, mental health peer support worker type programs, a whole bunch of different qualifications at certificate level and graduate level cover elements of this. So I don't think that there is one particular type of person. I forgot to mention psychologists. How could I do that with Genevieve online? A whole bunch of our discipline areas, including nursing, cover those content areas in their skills. But beyond that, overseas, I've certainly seen people who've been teachers or who've worked for not-for-profits or who've had a lot of lived experience themselves, being upskilled and supported to do these roles. So I think there's a variety of people that can do it. Some of it will depend upon the governance and oversight that sits around these people and how independently they're working, as well as the exact nature of the people that are being referred in to them and how those referrals are coming through as to the nature of the person that you need. But that's just my view.
Thanks, Tracy. Genevieve?
Yeah, I echo what Tracy has said. It is one of the key issues is a bit of an open question in the Australian context, at least, that link workers are not registered health professionals with AHPRA. They're not, there's no specific qualifications and training for link workers at this point. So I think what we need to do is think carefully about what those key skills are. And you are talking about some very complicated presentations. So, I do feel like we need a workforce that has got expertise of some sort, but I would be reluctant to try and tie that down to one specific discipline, for instance. So when I was on the selection panel for the link workers at the Mount Gravatt Ways to Wellness, we had people applying from a whole range of different backgrounds, people who had worked with NDIS, people who were nursing backgrounds. We had a couple of AMBOs, like a whole range of different people who were familiar with the community sector, as well as had that sort of health and mental health kind of training. We just happened to have one person with a social work background and one person who's got a background working with refugees and sort of, trauma sort of area. So yeah, at the moment it's not prescriptive, and I think that's one of the things in terms of understanding what supports and levels of extra training might be required is still a bit of an open question here in Australia.
Thank you. I think this is the first time we've had people from Western Australia on a QPHCN meeting, so welcome particularly. And there is a question, does anyone on the panel know about any work happening in WA?
Yeah, so when we were doing our looking for sort of collaborators to do our benchmarking study, we were chatting to a group in WA in Mandurah who are running a social prescribing project for seniors. So it's called Out and About. So I guess people could just Google them and find out more if they have older clients in the Mandurah sort of area. I'm sure there's a lot more than that going on in WA, but I'm sorry that I'm not fully across what's happening in their state.
That's fine, thank you. Yeah, worth checking that out. We might look into that as well. And we are going to be sending the presentations, the PDFs of the presentations, and there's a few links and things in the Q&A panel here. So we'll put all that in an email. So if you haven't had time to jot something down, you'll get all that, and we'll see what we can find out about what's happening in WA and include that. Okay, I think, apologies if there is a question I've missed, but I think we have covered the majority there. And so I am conscious of time, and I know people have busy days ahead of them. So we might wrap it up there. So thanks once again to our panel, Genevieve, Edie, JR, Joe and Tracy. And thanks also to the checkup staff who have been working behind the scenes, Sabrina and Martina particularly, making sure everything works. There is a final poll question there if you'd like to answer that before you go. We'll follow up with an email, and we're already starting to think about our 2021 topics. We usually have one in the middle of the year on reconciliation, usually one on mental health specifically. I think social prescribing might join that list of regular topics. And yeah, we're always open to suggestions. So please get in contact with me or one of the team if you do have something you'd like covered in one of these meetings. All right, well, thanks everyone, and we'll sign off. Have a great day. See you.
Thank you. Thanks for having us.
Bye everyone.